My name's Candace Savage. I'm with the Massachusetts Medical Society, and it's been a pleasure to be part of the planning group here. At this point, I'd like to introduce our moderator, Dr. Janet Jankowiak. Dr. Jankowiak is the former director of the Brain Injury Rehabilitation at Radius Specialty Hospital in Boston. It's formerly known as the Jewish Memorial Hospital and Rehabilitation. She's a graduate of the Faculty de Medicine in France, Louis Pasteur. She's a board-certified neurologist with special training in geriatrics, behavioral neurology, and is a certified member of the American Society of Neurorehabilitation. I can tell you that Dr. Jankowiak was a member of our task force on medically impaired driving at the Medical Society. She's the past chair and a current member of the Committee on Geriatric Medicine. So please welcome Dr. Janet Jankowiak.
Thank you so much, Candace, and welcome to all of you. Welcome to the medical behavioral tract of identifying medically at-risk drivers. As you just heard, the tsunami of baby boomers who have reached 65 is definitely upon us. They are living longer than any previous generation, and with that, they are expecting more out of life. Many of them are in denial regarding the ongoing aging process and value their independence, which includes driving. Today, we are going to, as I would say, tickle the topic of medical and behavioral access and issues that may put them and others at risk when they are behind the wheel. We, as a society, need to work together to figure out how to help them safely maintain their independence as long as possible, and then provide them with reasonable alternatives when driving is no longer realistic. For our discussants today, I would like to just have an idea of who is in the audience. Can you raise your hand, please, for those who are healthcare providers? Okay, so good number of you. Do we have any engineers? Oh, I'm so sorry, because I was really hoping, oh, there's a brave engineer, excellent. We love having you here. I was hoping that this session would indeed be a cross-pollination, and by being in different disciplines that are not usually aware of the expertise of the some of the medical issues, that we can get a collaboration and really work together to solve some of these problems. And then who is in law enforcement? A good handful of those also. Thank you for attending, as well as I will term these other older adult advocates. So I'm going to include, I guess, the rest of you. So thank you so much all for coming. In the interest of time, any of your questions, please jot them down, and then we'll discuss them at the question and answer period, which will follow our first three all of our speakers. Since there are detailed bios already available in your handout, I will just mention some of the highlights of our first three speakers right now in order of appearance. After their presentation then, and before our question and answer discussion, I will introduce our fourth speaker, our fourth presenter, Mr. Scanzera. So I have the pleasure of introducing our first speaker, who is Dr. Brian Ott. He's a professor in the Department of Neurology at the Alpert Medical School of Brown University in Rhode Island, and director of the Alzheimer's Disease and Memory Disorders Center at Rhode Island Hospital. His primary research interests focus on the effects of aging and dementia on driving in the elderly. Following him will be Elin Schold-Davis, an occupational therapist and certified driver rehabilitation specialist. She is the Older Driver Initiative Project Coordinator for the American Occupational Therapy Association, which works collaboratively with the MIT Age Lab and the National Highway Traffic Safety Administration to study and promote safe mobility for seniors. And our third speaker will be Ann Hollis, also an occupational therapist. She is at the BI Deaconess Medical Center. She originally trained as an occupational therapist in the United Kingdom, and for the last 10 years has specialized in driving safety as the OT for DriveWise, a nationally acclaimed driver evaluation program, which provides objective evaluation of driving safety for people who have experienced neurological, psychological, and/or physical impairments. And at this time, I would like to ask Dr. Ott to lead us in our discussion of identifying medically at-risk drivers from a neurologist's point of view.
Hey, thank you for that introduction, and thank you for the privilege of talking to you today about one of my favorite topics, identifying medically at-risk drivers among the elderly. I have two main objectives. First of all, I'd like to identify some of the more common medical problems that lead to unsafe driving in our older drivers, and also provide some additional background to help people in their plans to develop strategies to screen older drivers for potential driving problems. I know in the first session we saw a lot of statistics about older drivers, but just to reiterate, older drivers, is there a problem? Yeah, I think the answer is yes and no. In terms of no, the number of crashes that older drivers involved in total are relatively small because they drive less than younger drivers. But if you look at their involvement in fatal crashes and whether they're likely to be at fault when involved in those crashes, you see an uptick after the age of 60 and beyond up into the age of 80, which is a concern. In 2012, over 5,000 older adults died in crashes and another 214,000 were injured. Older men are particularly vulnerable because they drive more than women. As we talked about in the first session, the contributing factor is a greater frailty of older people that makes them more vulnerable to die in car crashes, and in particular side impact crashes that they're particularly commonly involved in compared to younger people. This graph was shown previously a couple of times, showing the increase in crash involvement according to age on a per mile driven basis. And the good news is that over the past 20 years, the actual frequency of crashes per mile is at least decreasing. The main point, I think, of my talk is that age really isn't the problem, though. Although you see these statistics about older drivers, we've been doing road tests and naturalistic research studies on not only dementia drivers, also normal older drivers for comparison, and just critically analyzing their driving. As a group, older drivers who are healthy are good drivers. They're not the problem. So I always kind of feel uncomfortable with talking about the risks of older drivers in terms of getting into crashes and being involved in intersection crashes and so forth. The real problem is that age is associated with an increased risk of having medical problems, and it's these medical problems that increase the risk of getting into a crash. And so that's what I'm going to focus on in my talk this morning. There are three main domains that we look at in terms of the disorders that affect older drivers that can impact their driving safety: vision, visual perception, physical function, and cognition. So we'll talk about these disorders and break them down according to these three main areas of concern. The first one is vision. This slide shows the most common disorders of vision associated with impaired driving among the elderly. Probably the most common one is cataracts, affecting 50% of people between age 65 and 74, and 70% of people over the age of 75 years. Cataracts in general restrict visual acuity and can impair contrast sensitivity, causing problems with judging distance as well as seeing things. The crash risk of cataracts is estimated at 1.3 times that of other older drivers who don't have cataracts. In one study by Cynthia Owsley and colleagues, they showed that one could reduce this crash risk after cataract surgery by as much as 50%. So another important take-home point from my talk is if we can identify some of these medical problems, we may be able to do something about them in terms of reversing crash risk in the elderly. Another common disorder is glaucoma, which causes blind spots and can affect peripheral vision, making it difficult to see things like vehicles and pedestrians. The crash risk in glaucoma is estimated at 1.7 to 5.2 times that of older drivers without glaucoma. Macular degeneration is another disorder that affects retinal function, particularly central retinal function, and so people, of course, will have difficulty seeing things in their main site of vision. So obviously, you would think this would cause problems with driving, although the exact crash risk associated with macular degeneration is unknown as far as I know, and it's an area of active investigation now. Diabetes can impair driving abilities in a number of different ways, including vision. Diabetic retinopathy is very common among particularly insulin-dependent diabetes with a prevalence of 70%, and can lead eventually to total blindness. The crash risk associated with diabetic retinopathy is estimated 4 times that compared to older drivers without that problem. In terms of physical function and motor function, in general, aging is associated with a decrease in speed and coordination of movement. It's associated with a reduction, or slowing rather, of reaction time. And as you well know, older drivers, as a result, compensate by driving more slowly and more carefully. And they also self-regulate. They tend to drive in routine areas only during the daytime in familiar territories. And in these familiar restricted environments, they drive as if there's no impairment at all. They do just fine. Where they run into problems and challenges is when they're outside these familiar environments and territories, or faced with unusual or emergency situations or surprise maneuvers by other drivers who may be even more impaired than they are, such as teenagers. Among the major physical conditions that can really have an impact on motor and physical function, arthritis is probably the most common one, affecting 80% of people in their 70s, leading to loss of dexterity, affecting their ability to use controls. A big problem is reduced range of motion, particularly the neck and looking side to side and checking blind spots, and a general reduction in motor ability to handle the wheels and the controls. Another neurologic condition that affects physical and motor function is diabetes, can cause peripheral neuropathy. It can have an impact on the ability of the feet to operate brakes and clutch and the pedals. Among other neurologic conditions that affect motor function, one has to consider Parkinson's disease, which can impact driving in a number of different ways. Parkinson's disease is associated with bradykinesia and rigidity that can affect steering ability, braking responses, and in our research, in particular, we found they have a lot of difficulty with head turning. They tend not to do it. And another problem with people with Parkinson's disease is up to a third of people will have some degree of cognitive impairment that can affect their judgment and driving abilities. People with Parkinson's also have sleep disturbances, and they experience adverse drug side effects of the medications they're using for treating their Parkinsonism. So these are all things that we need to pay attention to and can potentially be impacted by adjustment of therapies. Among other major medical conditions that also can affect alertness other than Parkinson's and the medications for it, a common one is obstructive sleep apnea, which leads to excessive daytime somnolence, and this is readily treatable by the use of positive airway pressure devices during the nighttime to reduce the daytime somnolence. Elderly people are prone to cardiovascular disease and seizures, which cause abrupt loss of consciousness and can cause major accidents. How one deals with arrhythmias depends on the particular type of arrhythmia and how it responds to treatment, prognosis for response, and the use of devices such as pacemakers in terms of whether people need to restrict their driving. So the epilepsy is not unusual in elderly people. The most common cause of epilepsy in the elderly people is stroke, which is a common disorder. Recommendations on restriction of driving due to epilepsy vary from state to state. In Massachusetts, the recommendation is 6 months seizure-free. Rhode Island, we don't have a stipulated seizure-free interval, but most states have a range of anywhere from 3 to 12 months before return to driving of being free of seizures. Again, diabetes shows up as a condition that can affect alertness, not just peripheral function and vision. It can cause hyperglycemia, hypoglycemia, leading to drowsiness and actually loss of consciousness or seizures. And so attention to close diabetic control is important. Elderly people, for elderly people, medications are a particular concern. The elderly people as a group use more medications than younger people, and because of this, they're more prone to adverse drug interactions and adverse drug side effects. I think there's an increasing awareness that this is a problem and one that's potentially manageable and we can improve upon. Antidepressants, antihistamines, benzodiazepines can cause drowsiness and blurred vision and decreases in motor coordination. Some antihypertensive agents can cause dizziness, fatigue, even confusion in some cases. Analgesic agents can also cause confusion and slowed response time, and this can be accentuated by the concomitant use of muscle relaxants in treatment of disorders such as arthritic conditions and low back pain. Not only is it important to be alert to drive safely, but good cognition in general is important for safe driving. Memory, as it turns out, is not a particularly high risk factor for getting into a crash, but it is important. People who have impaired memory may have difficulty finding their destinations, and this can be a problem when elderly people are driving in unfamiliar territories, unsafe weather, or in foreign environments, or they run out of gas and so forth. More important in terms of crash risk itself are deficits in visual attention and perception. There have been many studies showing that limited field of view and visual perception are particular risk for elderly people getting into crashes, and there are ways of measuring these types of deficits. Problems with executive function, higher order thinking, planning, decision making are important for safe driving. And so, as you would expect, a medical condition such as dementia, which is also very common among the elderly, increases the crash risk for elderly people significantly. It's up there in the top group of at-risk medical conditions, with the risk equal to that seen in people with alcohol abuse, schizophrenia, and sleep apnea. And well, that went automatically. The risk is higher than that seen in people with epilepsy, cardiovascular disease, other psychiatric disorders, diabetes, musculoskeletal problems, and vision disorders. Common errors that are particularly made among Alzheimer's disease people are forgetting, of course, where they're driving, difficulty with navigation, which may be related to memory as well as visual spatial problems, failure to anticipate traffic situations, and reduced problem solving as a result of executive function deficits. One thing we see particularly commonly in our own research is problems with keeping in lane and choosing lanes, and as well as failure to check blind spots. So the problem with the elderly driver with cognitive impairment or dementia is not should they stop driving, but when should they stop driving? And to try to help answer that question, we completed a longitudinal study of drivers with dementia and compared them to normal controls, followed these people every 6 months with on-road driving tests and office tests. And so we see these survival curves, and in the top one, the blue line, is the curve for people with questionable or very mild dementia, often including the people we call mild cognitive impairment. And what we found is that people with this degree of cognitive dysfunction, on average, continue to drive safely without failing a road test or being in crashes or being too demented for about 2 years on average. If you look at people who originally have mild dementia, clinical dementia rating 1, those people have half the survival in terms of their ability to continue driving, and on average need to get off the road or were taken off the road after about a year. And so these figures give us a general ballpark to work with if you're advising an elderly driver's first diagnosis of having a dementing illness in terms of how long you have to work with them, in terms of when they're actually probably going to need to stop driving. And so our practice in the memory clinic has been to start that conversation at the very beginning, if you can, about the future and to try to get people to taper their driving and restrict their driving gradually rather than waiting until it's really a crucial problem and trying to take the case away abruptly, which is very emotionally disturbing and difficult to do. So a little foresight is important. So the key message I'd like you to walk away with this morning are, first of all, it's not age that's a problem, it's the ability. And abilities are affected by age-associated diseases that can impact a person's driving safety. These abilities can be tested, and we're going to be hearing more about that from our next few speakers. And in some cases, I mentioned, we can actually improve people's abilities and safety as drivers, depending on certain medical conditions that may be partially reversible or treatable. And lastly, driving cessation is a challenging and important decision in particular for older people with dementia. And this group, please do engage the driver and family early in the process of counseling and observation. And with that note, I'll thank you for your interest and attention.
Well, I can tell you as I go through this, my name's Elin Schold-Davis, and I'm from the American Occupational Therapy Association. And as I was listening to the whole list of different conditions, from my standpoint, I was thinking, we can help that one, we can't help that one, we can help that one, we can help that one, we can't help that one. And I really hope that as I talk through today, I want people to think about, imagine you were the person that he's talking about. Because I think driving is the one activity that of all the healthcare kinds of things I get involved in, and sometimes as OTs we'd sit around and say, I hope I never get a brain injury, spinal cord would be really difficult to deal with. Driving and aging is something we all aspire to actually age into. We actually hope to live into long life, and we hope to be able to be a part of participating in what we're talking about today. So I think it's really important that we think personally that we could have any of these conditions, and what would we want to have available to us to help us deal with this condition and continue our mobility. Preaching to the choir here, but my point of saying that driving is and will remain the primary mode of transportation is that when Beth and the speakers this morning were talking about our aging society, we need people to drive. It's really important that people who can drive are able to drive and that we facilitate their driving. And likewise, those that are no longer able to safely drive, we have to clearly identify them and help them transition to something else. But it's really important that we first think about helping, because driving represents the ability to maintain connections and contribute to the community. When we look at the demographics and the number of people aging, we need them going to your stores, spending money, getting their hair cut. We need them getting out of their house. We need them to be participating in their community. They want to. We need people to. So we need to make sure our systems that we have in place are facilitating participation. Studies show there's a relationship between health, sense of autonomy, and the ability to drive, and loss of mobility can lead to depression and low life satisfaction and health problems and whatnot. So the focus of my talk in this track is to really think about driving evaluations, interventions about driving as a service. And I think that one of the things that, in my impression over the last decade, when we started reacting to the anticipation of the senior tsunami that was coming and the high-profile crashes of Mr. Weller plowing through the Market Square in California, is there was a lot of energy around getting the dangerous old people off the road. And there was a lot of energy around testing to get people off the road. And I think we are dealing with a legacy right now that anything about evaluating driving or looking at whether driving is a concern is associated with taking my license away. And if you think of other health conditions, you know, cancer, the first thing, if we get diagnosed, the first thing is what can you do? What can we do? What can I do to treat this? What can I do to help this situation? And my biggest theme in my part of this talk is if we can think about evaluation around driving as getting the service to the person to correct what we can, help them stay on the road as long as we can. And I like how you talked about, Dr. Ott, that for 2 years of diminishing cognition from dementia, you know, we have time to work on this and think about this for some, not everybody, but that's where we have to really look at that individual and what's important for them. We have to prioritize safety, of course, for the individual and the community. But driving is not a perfect activity. It's not something we can measure exactly. And we know that from the 16-year-olds that start all the way to on the aging side, there is risk, and there is risk for crash associated. We want to do the best we can to have people as safe and prepared to compensate for their problems as we can. We want to build messages of wellness, that we are there to help you. And that way, we might bring, when you listed all those different diagnoses and all those different impairments, wouldn't it be great if people felt comfortable going into their doctor to say, I'm worried, I'm feeling like I'm hitting my mailbox, I'm having difficulty with my neck. Is there something we can do for my driving to make it safer? And we already talked about the frailty and fragility, but when I'm talking about for the next few slides, the risk for injury and the importance of evaluation, one is the risk of frailty and fragility as we're aging. We might be aging healthy cognitively, but we're more vulnerable in the event of a crash, and the different medical conditions, as Dr. Ott reviewed so carefully, that show with diminished cognition, physical ability, and or vision, we are at risk. I want to talk about distinguishing the tools that fall into the category of evaluation, because there's many different tools and there's many different entry points. And that's one of the things that we're finding in a community. You might come in through a traffic ticket and go into a DMV test and never get channeled into healthcare or having your problem looked at as something that might be corrected. In other areas, we do get that. We do get people referred back to their doctor and into the healthcare system. In some areas, you might go to you might have a very overly exuberant daughter who's been reading about older drivers and sees these warning signs. And I've had people come up and say to me, I took my mom's keys away. Maybe I overreacted. You know, so we have to really think about, there's a lot of entry points where people are getting the idea of evaluating or screening, but sometimes we're not making sure people are getting service to help them stay on the road. The purpose of different tools, there's many different tools and they're very good. Everything is good in its place at the right time. Screening tools, there's many of them out there. There's some of them in the exhibits that we're looking at where people can figure out if there might be some changes in their vision or there might be some changes in their attention or concentration. If we use that tool and then jump to taking away a license or saying you need to fail, that isn't the purpose of a screen. A screen is to alert us that there's good reason to look further. There's good reason to bring it to your doctor. We have to be careful that we're using these different tools for the right purpose. Driving evaluations at the Department of Motor Vehicles are based on performance of the skill to be able to maneuver a vehicle. And I'm going to talk about how that differs from the comprehensive driving evaluation, which is by the occupational therapist looking at the combination of cognition, physical ability, and cognition, physical ability, and strength to be able to make sure that people have all the components that they might need when they are dealing with a medical condition that's throwing some pieces off, because people are very complicated. And we really need to think about that there is the conundrum. Sometimes we hope that people will just make a good choice and they'll make this decision on their own. But there's evidence that shows that individuals do not always make the appropriate decisions with regard to their own driving. And there's evidence that talks about people that even if their license is canceled, they continue to drive. And my reason for saying these is it's not just about a decision whether a person can drive or not, but we need the family and we need a bigger unit involved to ensure that people are mobile and people that may have cognitive impairments that don't remember they're not supposed to drive, protect them from access to a vehicle. And really the only way we affect safety in Massachusetts is if somebody who shouldn't be driving actually isn't driving. And that is something that needs a bigger team. One thing that we found at AOTA, at the American Occupational Therapy Association, in our work is that we began to understand that there was a lack of awareness of what all these different programs are that claim to have a role in assessing driving. This is a table. I'm not intending for you to be able to read it. I just want you to know that there's the columns, and I'll ask them to post this on the website. This was developed with the American Occupational Therapy Association and ADED, the Association for Driver Rehab Specialists. It's a first seminal document of trying to help people understand that there's a range of programs, because we would hear stories like a physician said, I'm worried about your driving, Mrs. Jones. You could either take the AARP driver safety course, or you could go get a comprehensive driving evaluation. One of them's $15, one of them's $400. And they were portraying them as the same. And, you know, and we had to look back and say, well, I guess we've never really made a resource out there that helps them understand the difference. So that is what we got to work doing. So this table describes different kinds of programs, community-based programs, medically based, and I was hearing from Dr. Ott a lot. One thing I want us to distinguish is the learning of the skill of driving a car and medical conditions that are putting us at risk. That's the conundrum we're really talking about. And going down the left, the vertical column, was really an interesting exercise, and I'm hoping that we'll continue to build this, which is, what are these programs? What are they intended to do? Who are the people that provide them? What are the credentials of the people that provide these programs? What is their knowledge base? What are the services that they offer, and what is the outcome? Some services, or somebody will portray an education program, which is great, but it's been put together and they've been trained in administering that program. Other programs, like a driving rehabilitation evaluation, has a very deep professional background and a training in the evaluation. Again, I'm just wanting to make it clear that there's a difference, and you're going to get a different service by the different provider, and you want to match the service with the provider. Just to go quickly over when I talk about the road test, because the road test is held out as the gold standard oftentimes for driving evaluations, and I want to make a distinction, again, between what different road tests are. There are different road tests administered by different people with different training, and they are not interchangeable. They're not all the same. Operational is the basic level of operating a vehicle, strength and ability to control the steering, reach and turn the signal, knowing how to maneuver the intersection, stopping at stop signs. This is what we teach in driver education for our kids. We focus on making sure that they have the operational abilities to control a vehicle, absolutely appropriate to be tested at the DMV level, because we're not looking at testing their cognition when these kids come in for their evaluation. We're looking at whether they can manage the car, if that makes sense. That test is a perfect match for what it was intended to do. And it gets a bit into, at the DMV level, the tactical of navigating and backing up and parking and maneuvering a K-turn and doing the different kinds of procedures to be able to control a vehicle. But it's very much about controlling the operation and the tactical maneuvers of a vehicle. I was hearing Dr. Ott talking a lot about, when he was getting into the concern, he was talking about executive function, being able to make shifts and be able to make changes in their if you run into weather, if you are really tired, what are you going to choose to do? At the highest level, the strategic level, is anticipation and decisions, route planning, judgment. Can I manage in this traffic? What are the responses to the unexpected? What are they able to inhibit experiences of road rage or being frustrated if somebody stops in front of them? These are the higher level skills that are evaluated at the level of a comprehensive driving evaluation by an OT, because that's really what we're aiming for. And as we think of dementing conditions or cognitively impairing conditions, people lose the higher level functions first and retain the lower functions later. So one way I like to describe it is, if people that shouldn't be driving couldn't drive, we wouldn't have a problem. We wouldn't be sitting here. The problem is people with impaired strategic abilities can drive. They can get in their car, they can make it go, and they can plow through market squares. So we have to really, it's really looking at, as we are looking at medical conditions, we want to think about making sure we put a medical test on top of that. Because we need the range of service that will help people stay on the road as long as they can. They won't react to an impairment that could have been corrected and make the conclusion a person needs to stop, when in fact we could be able to be helping them continue driving. And we really have to respect that abruptness of a medical condition that just takes driving off the table. That's really difficult for families, and I like how you talked about, as much as we can, we want to be preparing people as they have their diagnosis to be preparing for that driving cessation. And OTs are focused on doing this kind of work. And this is a nice graph to talk about that people in the middle, in the yellow, need more evaluation. These are the people when they go to the physicians or when they get into the system, we're trying to figure out can they drive or not. There are a number of people that are on the red side where they have enough impairment that we know that driving needs to stop. They have significant impairment in cognition or vision or physical ability. And there's people on the green side that might get caught in these screening tools or in the different processes we have. But when we really look at them, they don't really have any medical signs that need to restrict driving. So what we really want to focus on is people that fall into this yellow or follow into the area of we're not sure, making sure we get the right test for them to be able to continue to make the best decisions. They can either continue to drive with support or we can help them transition from driving. I just want to make a couple of plugs for a few of the awareness initiatives that we've been involved in that I think are working very hard to get the messages on the table early, both for the healthcare providers and for the public. CarFit is a project of helping people understand the importance of making sure the safety features fit their safety features are adjusted so they can protect them in their vehicle. The one thing I can say as the OT and part of launching this nationally, it is one of the first programs that sees an individual senior in their car that is not about taking their keys away. And we repeatedly, over and over, will have seniors say, but you really are just covertly trying to decide if I should stop driving or not. And we're working very hard to build the trust of the seniors in our community that we, in fact, are interested in helping them stay on the road. We are interested in helping people to be able to compensate for their problems, and Anne's going to go into some detail about all the different things that can be helped. If something can be helped, we need to do that. And if something can't be helped, we need to transition them to the appropriate transportation alternatives. So the other plug I have up there is our Older Driver Safety Awareness Week in the first week of December, where many of our different organizations join together to try to get the word out to the community about the range of services from anticipation and awareness and fitness all the way to transportation alternatives. Because the more we have efforts to try to get the word out, the more I think we can help get buy-in from our seniors. So with that, I'd like to introduce Anne, and she's going to come and really tell you what a driving evaluation is all about. Thanks.
Thank you. So thank you for setting me up, and thanks to both the previous speakers for fantastic presentations. So I'm Anne Hollis. I'm from DriveWise at Beth Israel Deaconess Medical Centre. And I want to talk to you about how clinicians can screen for driving safety, and also to tell you about our program, a description, and some of the key tests we use, which are probably common to a lot of driving evaluation programs. So to start with, thinking about how clinicians can identify who needs to come to us, well, they can use cognitive screening tests. The advantage is they often commonly use these. They take 15 to 20 minutes to administer, and they don't need any specialist training. Or another way to do it is to do interview-based screening tools. Very fast and simple, part of a standard medical interview. For screening tests, one of the most commonly used is the mini-mental state examination. It looks at orientation, registration, attention. It's scored out of 30, and many, many physicians use this. But this wasn't developed for driving. So when you look at the mini-mental state examination and driving, the research is variable. Some studies say it is predictive of driving safety, and Odenheimer suggests a cutoff of 24 or less. But other studies equally show it isn't predictive, and there's no association with motor vehicle crashes. An alternate test, a more recent test, is the Montreal Cognitive Assessment, the MOCA. It's a harder test. It's still scored out of 30. It covers more domains: visuospatial domains, naming, memory, attention, language, abstraction, etc. However, this also wasn't developed for driving. And when we looked at the literature, we couldn't find much about the MOCA and driving, so we decided to do the study ourselves. We looked at 92 adult drivers, and we found that out of those, we had a group of people who had been referred to us with known cognitive impairments or conditions associated with cognitive impairment. And we also had people who had conditions not consistent with cognitive impairment. And when we looked at them separately, we found that with cognitively intact people, neither the mini-mental state or the MOCA was predictive of driving test outcome. Not that surprising, really. A cognitive test doesn't... people who haven't got cognitive impairment should do well on a cognitive test. However, with people who had a known cognitive impairment, the MOCA was a better predictor. And specifically in our cohort, as the MOCA score decreased by 1 point, somebody was 1.36 times more likely to be unsuccessful on our Rhode evaluation. And we suggest a cut score for the MOCA of 18 or less, so hopefully that's going to be helpful to clinicians. Interview-based tools, again, I'm going to talk about ours. I know our research the best, and I'm going to promote that. And ours is called the 4 C's, and the C's are crash, concern, clinical status, and cognition. They're not the ones for the diamond, which also has 4 C's. And it's modelled after the CAGE questionnaire, and the CAGE questionnaire is for alcoholism, and it's questions that the physician asks as part of a clinical interview. So this is what the 4 C's looks like. We've got the 4 domains, and each one is scored from 1 to 4. And this is just as the clinician's interviewing the patient, they think about, and their family, they think about these domains, and then they score it afterwards. So in our research, we did a retrospective review of 160 DriveWise records, and we found that the 4 C's was significantly associated with on-road outcome, and the most predictive domains were concerns and cognitive functions. And interestingly, 95% of those with a 4C score of 9+ were marginal to unsafe on our on-road evaluation. If you look back, gone back one, you can just figure out where you get 9+, the maximum is 16. So we feel that's a good screening tool that can just help people figure out whether this person needs to be looked at more closely. So now I want to talk about our driving evaluation program, which is called DriveWise at Beth Israel Deaconess Medical Center. We're part of the Division of Cognitive Neurology. And this is what people think we are, but we're not. I hope we're not that. So our clients, over 600 individuals with a wide range of medical conditions and problems, and our age range has been from 17 to 97. And the 97-year-old gentleman did very well and was successful and was safe to carry on driving. I won't say he's still driving because that was several years ago. If you look at the demographics, although I said it's 17 to 97, the majority are older, which is to be expected. So we're an evidence-based assessment. We try and keep up with the latest research. We do our own research. The assessment starts with a clinical social work assessment. My colleague Lisa Kapust is here today speaking at one of the other tracks, so I'm not going to speak about that. And then I do in-office testing, and myself and a certified driving instructor do an on-road evaluation. And then usually a couple of weeks later, the person comes back, the patient comes back for a feedback session at which they get the outcome in both verbal and written form. The reason for that delay is that in the interim, we get together, we talk as a team, we look at all the different tests. We have an eminent neuropsychologist who consults with us on all the cases so that we're sure that we're looking at this thoroughly. The OT assessment is all the things that both Dr. Ott and Elin have talked about, vision, cognition, physical function, and on-road. And the vision testing, acuity field, tracking, depth perception, standard things. Dr. Ott mentioned contrast sensitivity. And I also want to I'll talk about that a little bit, and I'll talk about useful field of view. So that's a contrast sensitivity chart, just to give you an idea of what we're talking about here. They start out really clear and they gradually fade out. So people who have difficulty with contrast sensitivity are going to have more difficulty driving in conditions when the light is poor, so when it's foggy, when it's rainy, when it's twilight. So just to give you an idea of that. Useful field of view is what you see in a glimpse without moving your head. And that's just a representation of what that means. But the useful field of view test, which was developed by Carleen Ball, a 3-part test, looks at visual processing, divided attention, and selective attention. And that's been found in many studies to be predictive of both road test outcome and predictive of at-fault motor vehicle crashes. So we feel it's a powerful test. So that you have a look at this, I've just got a demonstration of useful field of view 2. What's going to happen is it's going to pop up and there'll be a white box with either a car or a truck in it, and somewhere else around it there'll be another vehicle. Let's see if I can make it do it. Hey, there it goes. And then it asks you 2 questions. Which was in the white box, which in this case was the car, and where the other vehicle was, which in this case is at number 2. I'm sorry, they're rather old, but to give you an idea of what the test is like. And this happens multiple times and gets faster and faster, and then the program will give us a score that we can help look at norms to interpret. Cognitive issues relevant to driving are the ones that Dr. Ott talked about: attention to task and ability to divide attention, information processing speed, decision-making, and memory. And one of the tests that we use and that I think many people use is the trail-making test. This is trail-making test part B. Again, was not developed for driving, but is sensitive to divided attention. And many studies have found this to be predictive of driving outcome. I've cited Roy et al. Because this was a review, and this review study looked at all the many studies before it. Physical assessment, we're looking at strength and range of motion, we're looking at coordination, sensation, mobility, and then we're looking at brake reaction time. And this is a brake reaction tester. It's not my photograph, but it's the type of tester I use. And when you press the gas pedal in this little gizmo, the green light comes on, and then the evaluator can press a button and make the red light come on, at which point the patient has to hit the brake as quickly as they can. We do that multiple times, and it gives us a measure of brake reaction time. Very reassuring to me, since the next thing I'm going to be doing is getting in a car with that person driving. It's really nice to know if they're going to be able to stop the vehicle. So, on-road evaluation is the gold standard for assessing driver safety. As Melissa Amick and Dr. Ott said. And we use a standardized assessment, which is based on the Washington University Road test. And it presents a wide variety of driving challenges. We have turns at traffic lights, we have stop signs, we have turns that with nothing to control them. We go on Route 9 is our highway, so we do a lot of different situations. And myself and the certified driving instructor both separately score the driving performance. And in our studies, when we've looked back at this, we found pretty strong inter-rater reliability between the OT and CDI scores. But any driving evaluation, and my colleagues will also say, I'm sure recognize this, is only a snapshot of driving. We're not measuring how someone can drive over their lifetime. It's an artificial situation. They're in a strange car, they've got a driving instructor next to them, they've got someone in the back seat, they're going on a route that they don't know. So it's a 1-hour snapshot. And this is particularly difficult in people whose function fluctuates, like those with Parkinson's disease. How do you measure? How do you take an accurate snapshot of a fluctuating condition? It's very difficult. The outcome of our evaluation, well, the good news And excuse the terms pass and fail, we don't use those with the drivers themselves, that's just shortcut for this. The good news that even though the people have all been referred to us with concerns about their driving, is that 44% of them we find to be safe to continue driving. 39% we suggest should retire from driving, they're not safe. And then there's this other group, the 16% who have maybe made some errors, potentially serious errors, but we feel have the potential to remediate, to go away, work with the driving instructor on those specific errors they made and improve their function. So we don't want to just do yes, no, there's that third category. So I've got some ideas about improving things for older drivers. Infrastructure improvements. There's a whole track here on infrastructure with some great experts, but what I would just say is that anything that helps older drivers is going to help all of us. A dedicated left turn lane, helping older drivers, I think is going to be great for us all. New technology in vehicles, again, there are experts here for that, but just things like blind spot indicators and training to improve skills. I'm thinking of the online trainings like AAA and Euroracer, Lumosity. Adapting the vehicle for physical limitations, we have experts in that here. Don Sampson's at the back of the room. I'm certainly not going to lecture to him about adapting vehicles. And strategies for individual drivers. It may be limiting, suggestions to limit driving, so saying avoid the highway, avoid rush hour. I came here on the highway at rush hour. I certainly wouldn't recommend it. And minimizing distractions. We all know cell phone is a huge distraction, but it may also be keeping the radio off and the windows up. In conclusion, some simple tests can help screen who will benefit from a driving evaluation and help the clinician decide. In-office tests, while they're predictive, are not enough. They don't tell us the whole story. They're parts of the puzzle. The on-road evaluation is currently the best measure we have. That's the biggest part of that puzzle. And as Dr. Ott said, age alone does not predict poor driving. Thank you.
Thank you so much. I think these have been very, very stimulating conversations. And now we would like to move on to Eugene Scanzera, who is the Vice President, Senior Markets for Harvard Pilgrim Healthcare. He has extensive background in the Medicare space and is currently working to develop and promote Harvard Pilgrim's senior market portfolio. He has the dubious task of having listened to these three speakers and envisioning for us in the next 5 minutes or so what this may mean for Massachusetts in the next 5 years. So,
identify common themes and common threads and say something provocative and then open it to questions. So that's what I'm going to do. The one thing, you know, I'm in healthcare, and I noticed when we went around the room earlier and people raised their hands, a couple of things came to mind. One is, you know, when it comes to the common themes is that it's function, it's not age. And the other is that things can be remediated and prevented. And so I'm in healthcare, so how do we link these two things up? And a lot of what was said here today, and I'm not a clinician like the experts who talked in front of me. I'm an HMO hack, and so I really can't get into detail, nor would I. But a lot of what was said was, how do you identify the person who has impairment? And so in healthcare, what we try to do is, how do we prevent that impairment? Where is the intervention? How do we intervene in order to prevent the accident from happening? Best example, exercise. How do we keep people and their hearts healthy? We exercise. We eat well. I see a parallel here. How do we keep people on the road? We keep people on the road by telling them, to do something that we tell them to do with everything. Get off the couch. Just get off the couch. Go take a walk. Go do something. And I think that there's a message here. And I work in the senior markets, and for those of you lucky enough not to be in Medicare, with Medicare, helping somebody on Medicare, the prepaid health plans are rated by the government by stars. And these stars indicate how well you do in preventing disease in your plan. How many screenings do you do? There's a score for mammograms of women of certain age. And there's scores for how many, and it has to be evident in the medical record, how many people in your plan had their physician talk to them about fall prevention. And that's not talking about the endless summer, that means falling down the stairs. Next, how do you, is it in the medical record that the physician talked to this person about smoking cessation? So I think here, there's a message about driving. In the earlier session, talking about all the baby boomers who are aging. Okay, I'm one of them. I'm smack dab in the middle. And I've been in this thing for my career, and essentially what baby boomers want is, how do you keep this machine functioning so that I can still play golf, ride my bike, etc.? And I think the message can and should be extended to, how do I keep the body and still be able to drive? Because I think for baby boomers, it's a big deal. It is for me, and the world revolves around me. So I think that there is the opportunity for, one, a health plan to be evaluated on how they screen for somebody who is a driver. Because it's not just a public safety issue, it's a health issue. Second, I think there's the opportunity for developing something and messaging to the member about how to be able to stay on the road. Here is an exercise regimen. You need to get off the couch. You want to stay in the car? Get off the couch. Here's an exercise regimen that will keep you healthier for being on the road. I think that that's kind of the provocative thing I want to throw out there, because also as a discussant, you're supposed to say, what's the next level of research or advocacy? That's all I can think of. So that's my 2 cents, really. So thank you.
Thank you so much, Eugene. I actually think you did a great job of that, because I think it is all in prevention. Eugene mentioned particularly that it's prevention of health issues, and he referred particularly to physical. But at the same time, we know that a lot of these issues are definitely cognitive. But what is good for the heart is also good for the brain. And I know Dr. Ott will certainly agree with me on that one. We were opening it to questions at the moment, but one thing that I would like you to consider, and I'm going to open this to the panel, is the issue of multitasking. I think very often that has been alluded to in terms of executive function and what happens particularly at left-hand turns, which we know are the most dangerous, but I would like you to have a little better understanding of what it is that makes left-hand turns so terribly difficult and why it's particularly risky for an older person. And I will start by saying that the ability of a 17-year-old and a 70-year-old to divide attention is very, very comparable. And I think that is why you see these two peaks in crashes at those two levels. And it was mentioned at one time, just by Anne, that when you are doing the driver's testing, operational testing, that it's fine for the young driver. I propose that maybe it's not. Maybe we also need to be doing strategic testing on the young drivers, because a lot of their accidents, I think, are due to not yet developed frontal lobes, the part of your brain that deals with executive function. And I think that that is part of what is going on. I would like the comments of some of my colleagues here, whether they agree with that. We're not quite, oh, okay, I guess I'll stay up here and then we'll just pass the mic around then. Excellent, good, perfect.
Well, starting at the end and going backwards, I would love to see more emphasis on cognition for the younger driver. And there are some really great OT programs right now that looking at autism and Asperger's. And you know, as one of my soapboxes is we have extended time for these kids in many special ed issues. Somebody didn't like what I said.
Do you want to come stand? Do you want to come stand up here?
Anyway, but there really are special programs to be addressing
Go.
Cognition for the novice.
Come join me up
Come
here.
on up, you guys. For the novice driver, absolutely. You know, we're canceling driver's ed. I mean, we don't even. And the other issue with driver's ed for kids is if you have a special needs kid, they oftentimes don't take driver's ed when they're in school. They wait until they age out of the requirement for driver's ed, so they don't even need it because they wait till they're over the threshold. Anyway, so I love that idea, but I do think, yes, I think the ability to look at the cognitive, the multitasking is excellent. And in terms of, you know, the intersection crashes, there's a memory piece that you've checked and you look back. There is the dividing your attention that, you know, one of the crashes we're seeing for left-hand turns is the cars go to your right and they go along with them and they turn in front of cars because they're kind of following the pattern. The light turned green for those cars and their red arrow, they're not paying attention, they're not dividing the attention between the two.
Along with that divided attention, will you say something about the distracted driver, and particularly what happens with cell phones and whether handheld does anything?
I think it doesn't matter what their hands are doing. I think it's what their head is doing. I think that the hands-free is a little bit tricking us into thinking that, you know, if we're paying attention, particularly if we're paying attention strongly to a conversation that's dividing our attention, just as if you're singing along with the radio, I think that divides their attention and can be more distracting. So I think absolutely cell phones are, the more we are, again, the idea that the more we're weakening, whether we are fatigued and we are at a weaker state for our cognition, or whether you have a dementing condition and you're weaker at the best you can do, we are reducing our capacity to be doing multitasking at that highest level. Right. So I don't know if that answers your question. You guys come up here. This isn't working.
Please do.
I'm just the only one.
Yes.
That's a different discussion. No, it's a really complicated issue. It does sometimes. There's a lot of misinformation about coverage, and there's a lot of. It's something I'd be happy to talk with you separately. Sometimes the driving evaluations can't be covered by Medicare. They're chosen not to be because Medicare covers 20 cents on the dollar. And driving evaluations are 2 to 3 hours of one-to-one service. You can't do a group driving eval. So many providers decide it works much better as a fee-for-service because of the cost of it. So there's really multiple answers to that question, but there's an opportunity for advocacy so that we can get the right resource available to the individual and try to have more options in terms of the coverage. Coverage shouldn't be a reason you're not getting the service you need. That's a Pollyanna statement, but I believe it. You can maybe comment on the reimbursement in Massachusetts.
Yeah, I agree. Our service, our program is a private pay program, so people have to pay the fee to be evaluated. Now, that is obviously a factor. If somebody said to you, we think your driving is in question, we'd like you to take an evaluation, it's going to cost you $500, and at the end of it, we may advise that you're not safe to continue driving. It's a very difficult thing to put across to people that this is valuable, this is worth it, this is important. And I think most, if not all of the programs, certainly in Massachusetts, certainly the programs I know, are private pay.
If I can just add to that, as we get better, and we talked about, all of us, making sure the right people are referred to the right test. I use the analogy if you told that same person their brakes weren't working, and they needed a $500 brake job, would we say, just keep driving? You know, so if we know that somebody needs it, we need to make sure the evaluation they're getting is appropriate and that it is going to serve them in the way, in the service that they need.
Just to get back to the couple of questions you raised earlier, you know, multitasking, it's not a very prominent problem in the older drivers. We do naturalistic driving research now. I see Dr. Lau is in the back there who's helping us do that analyses. And we have people we've road tested, and then we put cameras in their cars and we see what they actually do for 2 to 4 weeks, and we observe them. And you don't see much multitasking. They may eat while they're driving, but they don't use cell phones and so forth. They tend to drive actually focused on straight ahead, ignoring the rest of the world. And that's the problem they get into. And along with that, making left-hand turns is a problem because we see some of our worst errors in people making lefts and ending up in the wrong lanes, even wrong-way driving. So that is a concern area. And another interesting thing we've seen is that because we've road tested people, people who are cognitively intact can do perfectly at a road test, but then we put the cameras in their car and see what they actually do. They're rolling through stop signs, going through red lights, all kinds of terrible behaviors because they're able to compensate and be on their best behavior when on the road test, so that's a limitation. But yet the cognitively impaired people don't have the wherewithal to be on best behavior, so I think for the cognitively impaired people, the road test still has some validity that's relevant. Gang?
Yes, please do. I'm sorry, we don't have the microphone.
Yeah, that's right. So I think you raised a very good question why the crash rate is high in old and also in young people. And you're talking about whether it's the possibility, there's possibility that for the young kids, they have problem with multitasking. But from the limited literature I am aware of is that actually the young kids, they are very good at multitasking. So nowadays they have cell phones and computers, they do video games. There's some study that's showing that because of this, they are very good at doing multiple things at the same time. And also recently there's an NIH study showing that they do a natural driving study. They recorded their natural driving and they found actually the young driver, they follow the regulation better than their parents. So they hypothesize maybe the problem is, like Dr. Ott said, many people just they're running the rolling stop at the stop sign, they run the red light. Maybe so that's why they hypothesize maybe the young drivers they don't know when it's crucial, it's important to prevent the accident. The middle-aged. Although they make some errors, that's just bad habits, but they know it's not crucial. It's sometimes okay to make those errors. But when it's crucial, they don't make errors. Maybe that's the reason. So, although, of course, this is not proved yet. This is just a hypothesis. So this is just another a possibility I like to raise to people.
Thank you. Thank you. Yes. Do you want to come up? And maybe we can hear you.
Speak loudly. I have a question probably for Ian. I wonder, you said the road test was the gold standard for assessment, and I wondered what the state of like simulator tests is, and that seems like it could be cheaper and safer as a community.
Yeah, as far as I know, simulators are used a lot in research, but in terms of clinical work and in evaluating on-road driving, there are limitations. One of the big limitations is simulator sickness, and that older people have a higher rate and suffer more severely with simulator sickness than younger people. Also, there's limited evidence as to whether there is a true carryover between what you see on the simulator and what you see on the road. I've been in a simulator and I say things like, what happens if I steer for the person and hit them? I'll give that a try. I know it's not real. I know it's a simulator. I know I'm not going to come to any harm, that other people aren't going to come to any harm. So I'm sure it's something that's helpful, but limited. And I don't know, Dr. Ott might have something to add.
Yeah, I agree. There's a problem with validation with real-world driving, and there's not been enough work along that way with different simulators, but I think there's potential. I think one value, I think, with simulated driving is if one's developing a treatment, you want to do a treatment trial, you'd like to have some standardized outcome to measure against. And road tests, they're standardized, but there's a lot of variables still, so I think in research settings, simulators may be particularly useful for that kind of outcome.
It looks like we have completed our session. Thank you all for attending. I hope this has given you some good information to work on, and that we can all move forward collaboratively to figure out how we're going to keep people safe and independent as long as possible. Thank you so much.